areas of nutritional support with some antioxidants in the actual reversal of certain precancerous lesions in the mouth. And this got quite a bit of attention and still has been garnering more and more attention. He's published his research in some of the very most prestigious journals, Journal of Oncology, Journal of Otolaryngology, and a number of the dental journals that I get have picked up and given a little bit of abstracts from his work. Dr. Garewal, I called him up a short time after seeing all this research and talked to him and told him we were coming to Tucson, which is where his home is, and so it was very, very opportune that we could get him to come speak to us. He is the research or assistant director of for cancer research. He's a professor of medicine, and he works here with the University of Arizona Cancer Center as well as the Tucson VA Hospital. Dr. Garewal has a degree in medicine as well as a PhD, and so he's going to be talking today on the role of antioxidants and the research that he's shown as it relates to cancer. Dr. Garewal.
Let me begin by thanking the organization for allowing me to speak today and for the very kind comments made by Dr. Fisher. It really is a great honor to present some of our work to people that are not directly in your own specialty. In fact, a lot of the work that I'm doing in the oral cancer area is probably more germane, or many of these lesions are more seen by dentists and oral surgeons than by medical oncologists. My own specialty is medical oncology, and I got into the area of cancer prevention and control as one of the research areas. It's one of the research areas of focus at the Arizona Cancer Center. We realize that if we are going to control chronic diseases, diseases like cancer or heart disease or almost any chronic life-shortening disease, our focus is going to have to be on prevention. What I'm going to talk about today will primarily be in the oral cancer prevention area and try to review with you what is happening in this field and focusing again on the antioxidant nutritional agents, simply because these agents, if the data holds up, if the information, if the type of research that we're doing, if the results continue to hold up, these agents have a realistic chance of being used for prevention. I mean, these are not drugs. These are not things that you require, prescriptions and monitoring for side effects and so on. And as my talk goes on, you realize the importance of the statement, because a lot of the prevention research in other areas that's going involves the use of agents that I would classify more as drugs than as nutritional agents or as agents likely to be used for prevention. Now, I got into this area after, as I said, my primary specialty is medical oncology, dealing with advanced disease. We see cancer when it has metastasized. And you pretty quickly realize even if you do develop a cure for that situation, it's not going to make an impact, not from the morbidity standpoint that the patient has to go through to reach that stage, nor from the mortality or cure standpoint. Okay. So let me begin by just a little bit about our cancer prevention program. It is an integrated program. A lot of specialties are involved in this program, and it's just not medical oncology. In fact, our role there is relatively modest. There are a lot, there's nutrition people, there's behavior science, biology, people generating ideas, I presume, and then we have our clinical trials program. So all of these people participate, and I really would like to give credit to them, because really without their work, we could not complete the types of studies that we'll be talking about. The other point I want to make, and this is again, I'm normally talking to medical oncology audiences, but things that you do for prevention, particularly things like reversing preneoplastic lesions, that has an implication not just for prevention. It clearly has an implication for prevention, but it also has an implication for people at high risk, people with early lesions, people where you know that, I'm sure most of you are familiar, you take out an oral cancer, even if it appears to be early, there's a chance for recurrence, which can be as high as 30 to 50%, and perhaps modalities that reverse or affect preneoplasia, particularly the more advanced preneoplasias, may have a benefit for that. And that's why I usually show this slide, the things that we do against cancer, which are listed out here, and I can't read this from here, but have an implication both for prevention and treatment. The various steps. If you take the very first step, which is preventing exposure to toxins or carcinogens, that obviously has most of its implication is for prevention. But as we go down here, suppressing preneoplasia, it can have a treatment effect. And by treatment, I mean intervening in a patient who's had a cancer. Okay, so it can have a treatment effect. It can also have a prevention role. And then as you go on, treating frank malignancies, obviously more or less, primarily a treatment issue than a prevention issue. Okay, oral cavity cancer, just by getting some of the basics out of the way, and if, please excuse me if this is very basic information for you all, but this is a disease that is very, very common. On a worldwide basis, this is the sixth most common cancer in the world. And in parts of the world where I come from, like India, 25 to 30% of all cancers occur in the oral cavity. Now that's related to things like chewing and do all sorts of various habits, like reverse smoking, where you put the lighted end in your mouth, and people do strange things. But it is very, very common that 25 to 30% of all cancer in certain parts of India occur in the oral cavity. And the same is true for areas like Philippines, parts of Latin America, and so on. So it's not an uncommon disease. In the United States, the numbers are shown here. This is if you include laryngeal cancer as a part of this syndrome, about 40,000. This is right in the ballpark of ovarian cancer, leukemia, lymphoma, diseases like that. Certainly it's not lung cancer and colon cancer or breast, which are the three sort of, very, very common cancers, but this is not an uncommon disease in this part of the world also. The causes are very similar to, certainly the identified etiologies are very, very similar to many other diseases. Smoking and alcohol, or I should say tobacco use and alcohol, are synergistic. Okay, that is, the two together have a bigger effect than just the effect of each alone. Each of those two are carcinogenic. Okay, it is estimated that something like 75 to 80% of oral cancer in the world today is caused by tobacco, either smoked or chewed. Okay, so what I'm going to tell you is not a substitute for stopping tobacco. I mean, that's a question asked thousands of times. Can we smoke and do this and then take these compounds? That's not so. Okay, tobacco is a primary cause, and we really need to deal with that. The cancer is lethal. It is a lethal cancer. It's not one of the cancers that, like skin cancer, that you can deal with and cure most of the time. It will kill you if it gets to an advanced stage, and I'll show you the data on that. But it's also a very morbid cancer. It's a cancer that you can't hide. People with oral cavity cancer who've had treatments, the lesion is visible. It's not something you can cover with clothes, and the impact of that on the psyche of the patient is just tremendous. The suicide rate on patients with oral cancer who've even been cured of oral cancer, they still have the effects of surgery or whatever, is tremendous. So it's a very, very morbid disease too. And finally, from our standpoint, it's increasingly recognized that I made general comments about the importance of prevention in general, but in oral cavity cancer, it's pretty clear that with all of this information, that the way to control it is going to be prevention rather than treatment. Okay, there are a couple of points I want to illustrate by showing this slide. And the theme of this is, again, why prevention? Why do I say prevention is the most important thing? One is, look at the bottom line here. What have we achieved by treatment advances? And really precious little in terms of improving survival. If you compare survival data from the 70s to the 80s or 60s to the 80s or whatever, there has not been an impact on 5-year survival improving. Okay, it's stayed about the same, about 50%, despite all the advances in treatment and so on and so forth. Now, that is not to say nothing has happened. Techniques, surgical techniques have improved, so the morbidity aspects, I mean, the disfigurement, et cetera, is much less. The toxicity of treatment is improved, but not in terms of cure rate, okay, despite everything that we have tried to achieve. And number two, early stage, late stage cancer. You would think that most of this cancer would be picked up early. People would see a spot and they'd come and show up. And by early, I mean things that are, say, ½ an inch or less, or that kind of a size of a lesion. But that's not so. At least half these patients still present with advanced disease involving lymph glands or very large lesions, et cetera, as can be seen. It's about 50-50, 30 to 40, or 60 to 70% here. Look at this number. This is a very important number. In advanced disease, we can understand that we cure about 30-40%, I guess, in the advanced disease situation, because it is advanced. If you ask a medical oncologist or radiation therapist or ENT surgeon what is the cure rate for early stage cancer, they'll give you 90% as the number. Now, which is correct. However, the 5-year survival is only 40 to 50%. And the reason for that is that these patients, even if they get their first cancer cured, have about a 3 to 5% per year rate of developing a second malignancy, which is usually in the lung, in the oral cavity or esophagus, smoking related, I presume, and it's usually lethal. And that's what makes it, this impact drops the survival to 40 to 50%. And it's also a tremendous opportunity for prevention research. You have a group of people who have a very high rate of developing a cancer in the next 3 to 4 years. So the second primary prevention issue, it really impacts very well and is an opportunity for prevention efforts. So that's just to illustrate the importance of prevention in this disease. Now, again, one other concept by way of background before we get into the meat of the discussion here. When we start talking about prevention of cancer, we have to start thinking about carcinogenesis as the disease and not just invasive cancer. This is very similar to atherosclerosis being the heart disease or coronary artery disease, and myocardial infarction being invasive cancer. Okay, carcinogenesis occurs over years. You know, some people think over since childhood or exposure to various agents, and it occurs over years, and you have to think of intervening, you know, at various times. And the importance of this, again, is that, you know, 2 to 3 year studies are not going to show you big differences in prevention. It's very different from treatment, where you can get an answer in 3 to 4 months or 6 months. This is, you have to think about carcinogenesis as the disease, just like atherosclerosis is the disease for myocardial infarction or MIs as the endpoint, similar to invasive cancer. Now, the rest of the theme of the rest of my talk is going to be to show you that these agents are inhibitors of carcinogenesis in the oral cavity. My focus is going to be on carotenoids and antioxidant nutrients, and we'll make a comment about retinoids. Now, let me start off by defining things here. Retinoids are compounds that are related to vitamin A in structure. Okay, carotenoids are compounds that are related to beta-carotene in structure. So you have the retinoid, and in general, one beta-carotene molecule gives rise to 2 vitamin A molecules, but the properties are very, very different. There's a whole host of synthetic retinoids derived from the vitamin A structure, and then there's a whole host of carotenoids, most about 300 to 500 that exist in nature as natural compounds. Okay, that's important. Retinoids in general are drugs. Okay, now if I was to ask you know, people involved in clinical research or clinical trials research, how do you prove that a compound X or an agent X prevents disease Y? And the answer, you know, if you've gone through a few courses in epidemiology or whatever in clinical trials research, will be to do a randomized, placebo-controlled, blinded study, et cetera, with the right arms, you know, placebo versus active agent, and show a difference. Okay? And that's all fine. Theoretically, that's correct. The problem is in prevention research, that becomes virtually impossible to do for a variety of reasons. And I'll come back to this at the end of my talk. Endpoint frequency. You take a group of healthy people, the endpoints are not all that frequent. Okay, you take 1,000 people, maybe 2 or 3 will develop cancer or in 6 months or whatever, you know, the numbers happen to be. And you take individual cancers like oral cavity cancer, and I'll show you some numbers on that. It just becomes impossible. It'll take years to do. The duration, maintenance of the blind. I mean, I have to sort of admire people who publish reports that they did trials with high-dose 13-cis retinoic acid, which is isotretinoin. the drug you use for acne, and did a blinded placebo study. I mean, I can tell who's on that agent overnight. I mean, it complains about headaches, their face is red, and so on. So you can't, maintenance of the blind becomes an issue. Can you keep people on placebo for so many years? I mean, these compounds, particularly beta-carotene, vitamin E, and all are so readily available, it just becomes impossible. What you end up doing is you start looking for populations where you can do it. And again, I'll illustrate at the end a couple of trials that have been done, in China, or there was a trial in Finland and all. You go to places where you can do it, but then the question is that a representative population? And let me illustrate this with oral cancer. A few numbers, makes this concept much clearer. I asked one of our statisticians to calculate for me what number of patients and how long a trial would be required if we did that perfect study, randomized placebo, 2-arm study with an agent X with the placebo to show a 50% reduction in oral cancer. Big number, not 10%, 20, 50% reduction. I also asked him to assume that the incidence of oral cancer was 20 per 100,000 per year, which is much higher than what it really is. But everything in their favor. And these are the kind of numbers, if you make the usual assumptions of a clinical trial, are up here. If you want to do a 5-year study, you're going to require 104,000 subjects, okay, per arm. And nobody has to drop out. There's going to be not a single dropout rate. You can imagine the implications here. A 10-year study is 52,000. If you like a short, a long study, fewer patients, it'll take you 102 years. If you have a 5,000 patient subject study per arm. So it's very easy to keep saying you need a randomized controlled study and the perfect trial and all this kind of stuff. When you sit down to design it, you quickly realize that it's not going to be done. And so what do you have to do? You have to make decisions based on indirect evidence and evidence from other things than the perfect trial. And as the data accumulates, make up your own mind. What I've done here is simply listed up front the information available short of that perfect trial, which would take 102 years, of beta-carotene and oral cavity carcinogenesis. There's data from laboratory, epidemiology, pharmacology data, and what I'm going to go is illustrate each one of these for you today, and then see whether a case has been made or is more information required or whatever. Because the perfect study is not going to be done. Okay? So let's start laboratory. I'm not going to spend a lot of time. In fact, just the only slide. There's a ton of data showing that these compounds, carotenoids, retinoids, vitamin E, are very, very inhibitory to oral carcinogenesis, or to carcinogenesis in general. It's been shown in bacterial systems, in mutagenesis assays, tissue culture studies, and in animal experiments. Now, one animal experiment I want to mention is the hamster cheek pouch model. This has been used extensively for this type of work up in Boston primarily. The hamster has 2 cheek pouches, and you can apply DMBA, which is a carcinogen, on one side, and you get a series of changes very similar to what happens in the human. You get oral leukoplakia first, and then you get invasive cancer, and then you can put inhibitory agents and see if you can prevent this from happening. So it's really a pretty good animal model. I mean, still not human situation, but it's a good animal model, and in this system, all the compounds that I've been talking about are very, very inhibitory to cancer formation. Okay, so this compound has been used for a lot, model has been used for a lot of such screening studies, and the data is fairly strong, particularly the vitamin E, beta-carotene, and the retinoids. Vitamin C also is quite inhibitory to cancer formation in this model system. So that's animal and laboratory data, the first indirect evidence. Second was epidemiology. Now this is the strongest sort of information we have, and just like for many other things, if you have a diet that's low in vegetables and fruits, it's associated with a higher risk of these cancers also, like a higher risk for lung cancer and a couple of other cancers and heart disease and so on in this situation too. What surprised me was the unanimity of the evidence, which was kind of, when we looked at this data, what I've shown listed here is that this is about 2 or 3 years old now, number of studies done, number that were positive and number that were negative, negative meaning harm, okay, and the various diseases out here. And if you look at larynx and oropharynx, there were 13 studies done, and all 13 were positive. And that's a little bit too much for publication bias. I mean, I understand positive studies are easier to publish and all that, but I mean, these days, if you have a negative study, you'll get it published in the New England Journal of Medicine because you have a study that's going to go against the main sort of theme. Okay, but this is a little bit too much. For any study that has been done, comes out with the same conclusion. And look at, I've listed others for interest. I mean, lung cancer is pretty strong. and a couple of others. Look at colon cancer, where the data, I think, is a little bit iffy on the antioxidant issue, whether it has anything to do with colorectal cancer. And here you start seeing the display of studies. 35, 20 were positive. About half a positive, half a negative type of information that may not be as conclusive. But for oral cavity cancer, the data is 100%. So that's the second line of evidence. We had laboratory evidence, animal epidemiology evidence. Third is some interesting pharmacology data. Again, indirect, but very interesting. One has been known for a long time that the plasma levels of these compounds are much, much lower in people who use tobacco or smoke, that is, people at risk of these diseases, than non-smokers. Okay, this has been shown repeatedly. We have now gone ahead and shown that the same is true for mouth cells. You've got to show the target organ also, not just the blood, that at the target organ the same phenomenon occurs. And Stitch showed this a while back in studies he did, and we at Peng from our group a couple of years ago looked at the same issue and found this. And the data is quite striking, actually. This is from our own work, where in plasma, non-smoker level is about double. Oral cavity, same thing, about double. Buccal cell levels about double. And we actually went ahead and did some dietary questionnaires and what the intake and all was. You cannot go from this level to this level, smoker to non-smoker, by dietary adjustment alone. I mean, you'd have to eat a very strange diet. I mean, you could do it if you just eat carrots all day or something like that, but you can't, it's not practically possible to do that. So even if you allow for diet, there is a difference in the metabolism or whatever, maybe the compounds neutralizing toxins. I mean, certainly we would like to think that, but whatever the reason is, there is a difference in the pharmacology of these compounds in people at risk. Why don't we skip that? That's more for pharmacology. Okay, now, so just think again of the slide with the indirect lines of evidence. There's laboratory, epidemiology, pharmacology. Next is, what can you do in humans? I told you that perfect study, if you wanted to do it for 102 years, be my guest, but that's not possible to do. What can we do? We can look at 3 situations. In fact, if somebody has other ideas, I'd love to hear them. One is to look at biologic endpoints, and people have looked at oncogene changes and described these things happen with carcinogen exposure. The only real change that has any data is this thing called micronuclei frequency, and I don't want to spend too much time on that. Basically, if you look at these cells under the slide, you see dots of extranuclear material. It's thought to represent carcinogen or toxin exposure or genotoxic damage. And you can quantitate micronuclei. Okay, and people have looked, I'll show you some data on that. You can look at premalignant lesion reversal, a very important area, and you can look at that second primary question. There are people who have been cured of one cancer. This can be done in a reasonable period of time. Studies like this can be done in 1 year or 2 years, and not 102. Now, the micronuclei. This is a very controversial area. Stitch is the guy who's published from these 3 studies done in patients who chew almost all the time. I mean, these are chewers that, you can't quantitate amount of chewing, it's continuous. Okay? And in all 3 of these studies, he found a decrease in the micronuclei frequency. Now, in this country, where the lesion is from smoking primarily, we don't find an increase in micronuclei with smoking. So it's very difficult for us to show an impact in our population here, but certainly in places where the toxin exposure is much, much higher, the micronuclei were decreased by beta-carotene supplementation in all 3 studies that he has reported. So that's one thing that you can do in human beings. Now let's come to neoplastic lesions. Let me spend about 5-10 minutes on that, because that's an area where a lot of the recent interest has been. Almost all of us now believe that carcinogenesis is a process that takes over a long period of time and is a multi-step process, that cancer doesn't appear from normal, next thing cancer, that different steps are involved. This model, though, has been derived from laboratory data and from animal studies. And it's important to realize that all of these steps are very, very specific to the carcinogen used and the model used. Also important to realize that a lot of these things, when we talk about initiation promotion, I shouldn't say genotype here, I should say subcellular changes, that you can't look at the cell and say this has had initiation. You have to measure something like an oncogene or an enzyme or something or the other. Okay? Now, the importance of preneoplasia is that the first phenotypic change that you can see in your patients, that an organ or a mucosa has been affected by the disease called carcinogenesis, is when preneoplastic lesions appear. Okay, so that's why the first phenotypic abnormality, and people usually put it towards the end of this pathway, is when preneoplasia occurs. And that's why there's a lot of focus on trying to see whether you can move this way or this way when you're screening agents for potential cancer-preventive activity. Important to realize here that we're not treating preneoplasia. Preneoplasia does not need treatment. Nobody ever died of any preneoplastic lesion, okay? But you're using it as a model to screen for agents that may have an impact on the development of cancer. So it's a very, very important area for research. The significance, and I don't want to spend too much time on this, but you know, the importance, we use it in screening programs. Think of all the programs in colon cancer that are geared towards polyp removal, polyp being the preneoplastic lesion there. Adjuvant setting, let's ignore prevention trials, biology, you can look at changes that appear in preneoplastic lesions. That's the entire colon cancer model of different genes is based on looking at what happens in a large polyp, in a small polyp, in a dysplastic polyp, and trying to understand what the biology is in the human being. And I mentioned carcinogenesis in an animal model is not the same as in the human being. This gives us an opportunity to do some work in humans. And this is why, again, from our program is very heavily weighed towards intervention trials in preneoplastic lesions. I've just listed a few that we're working on. Obviously, we're going to be concentrating on the oral cavity cancer, leukoplakia, erythroplakia situation. A couple of important points about preneoplastic lesions, and I have the reason I mention is I have a lot of ethical concerns about some of the studies that are being conducted in preneoplasia. One is that they've been described for most all cancers. You name a cancer and I'll tell you a preneoplastic lesion. You know, you can say there's melanoma, there's dysplastic nevi, skin cancer, actinic keratosis, etc. Okay? Incidence generally greatly exceeds that of the corresponding cancer. Colon polyps. Colon cancer is very common in this country. Colon polyps occur in 60, 70% of the population over the age of 65. Okay? So leukoplakia in India, oral cancer is very, very common. Leukoplakia in that part of the world exists in 40, 50% of the population. Okay, so it's very, very common. These people don't have cancer and you cannot give them toxic agents. So many of these studies with high-dose retinoids and so on, I have a lot of concerns about because you have one toxicity that's irreversible. It's just not fair to the patient to be doing that kind of work unless you have a very serious preneoplastic lesion that's almost cancer. Rate of transformation to invasive cancer is generally low. Colon polyps across the board is about 1% per year. But, or leukoplakia, same thing, I'll give you some figures about that in a second. But you can define high transformation subgroups, very large polyps, villous adenomas, a lot of dysplasia in a polyp. And you can have rates of 5, 10% per year, a more serious lesion. But in general, most patients with preneoplasia will have a low transformation rate. Most polyps in the colon are small. You know, most leukoplakia is low risk. And here's some data on leukoplakia. Malignant transformation rate across the board about 1% per year or 2% per year. But if you have speckled leukoplakia or a lot of dysplasia, erythroplakia with a lot of dysplastic component, the rate can be 10 to 15% per year. However, for every one erythroplakia, in this country, for one erythroplakia, you have 30 non-dysplastic leukoplakias. So when you do a study across the board in leukoplakia, you know, most of your patients are going to be low-risk patients, and you've got to be careful that you don't give them agents that are going to cause calcification of the ligaments and all, like retinoids have some strange toxicities that you have to watch out for. This is the type of data proving that leukoplakia is indeed a pre-malignant lesion. The study is done in India where they've taken 30,000 people and followed them for 15 years. Every single case of oral cancer that occurred in people who had oral leukoplakia before. So the data is pretty reasonable that there's a link between the two. Okay, definition again, you know, I'm sure I'm insulting most of you in this, but the definition basically is a whitish spot in the oral cavity that you cannot ascribe to anything else or scrape off. It's a definition of exclusion. Okay, and this is from one of our patients who had quite a lot of leukoplakia. Standard treatment. You know, if you don't do anything, one is if it's a benign sort of lesion, I think all of them should be biopsied to make sure there's no cancer. But if there's a straightforward lesion, then just observation. If it's small, you can take it out. Problem is like the slide I showed you, you really can't take that whole thing out. But if that thing is developing a lot of dysplasia and so on, you can do things like topical bleomycin. These are standard anti-cancer agents, clearly no preventive role. This is just how to handle the lesion in day-to-day practice. And that's what should be done for most people. Okay, now, retinoids and leukoplakia, reversal of that. The first data on this came from Dr. Silverman, He's an old surgeon of tremendous reputation in this country. He's in UCSF. What he did in the late 1960s was use very high-dose vitamin A. And this is 300,000 units per day. It's going to rot your liver in 2 months, okay? So, but what he did was for a week or two, and he saw a lot of these lesions disappearing. For a week or two, it's a pretty reasonable and safe thing to do. Did not pursue it further simply because this is not a preventive modality. You don't give this and have people take that kind of a dose, okay? Now, a whole series of synthetic retinoids have been developed looking for potential for cancer treatment, cancer prevention, etc. There's a whole bunch of the drug companies making these, you know, there are thousands of compounds. The idea was to try to keep the anti-neoplastic or anti-whatever, you know, pro-differentiation type of activities, but to decrease the toxicity, particularly liver toxicity. And the compounds that most of us may be familiar with are the retinoic acids. There's 13-cis-retinoic acid. That's the compound used for acne, isotretinoin. There's a compound called atritinate that's been released for psoriasis and all in dermatology treatment. All of these were tested in the 60s and 70s and shown to have a 50 to 75% response rate in leukoplakia. Okay? However, still with too much toxicity to be used for prevention. There's dry mouth, there's headaches, there's this and that. It's just not something that you can say, okay, you guys go ahead and buy this. People have to be monitored and so on. It's not practical for preventive use. I put it in the same category of local bleomycin. Our objective here is prevention of oral cavity cancer. It's not treatment of leukoplakia. And I want people to understand that. I mean, it's not prevention in colon polyps. Is not, nobody ever died of polyps or leukoplakia, okay? So that's the goal. Don't subject these patients to toxic agents, okay? Essential properties of a chemopreventive agent, fairly obvious. And in the mid-1980s, when our group got into this field, there were two agents that looked very promising from laboratory studies, and there's been more work done with beta-carotene. Just for some reason, there's more interest in that compound. But vitamin E seems to be equally interesting, if not actually more. So let me show you some of the data now with beta-carotene and oral leukoplakia. Now, I used to go through all these studies, but it just takes forever to do because there are now 8 studies, the 7 or 8, that show beta-carotene can reverse leukoplakia in approximately the same percentage as the retinoids can, but without toxicity. And what I've done is simply listed all of these studies. The response rates is complete disappearance. Most of the people respond to overall response rate, which is complete and partial response being defined as at least 50% improvement, 50 to 100%, okay? And studies have been done in different parts of the world and are more or less this thing. Let's go over just a couple of our group study in Arizona. We did the first trial here where we took 30 milligrams per day of beta-carotene orally for 3 months. We wanted to see if there was any activity, and we looked for response. And this study has been published, so I won't spend too much time. The results, we had 24 patients. This is a straightforward phase 2 study. You need 24, 25. And there was about a 70% response rate, and it's been published in 1990. Important thing, no toxicity. Not a single, there's no dryness, there's no liver tests or anything that go wrong with these patients. This is how these lesions tend to respond. I mean, it's kind of more again for our oncology colleagues. This lesion is about 2 months into treatment. Originally, it's pretty dense white, the whole thing. And what happens first is it starts lifting off. And if this is going to get into a response, you know, the whole thing will sort of attempt to clear. You can see areas that are, you know, dense white before are beginning to clear in the edges here. Let me show you one that completely cleared. This is pre-treatment. The lesion is this thick white stuff. This is flash artifact that I have no idea how to avoid in oral photography. Perhaps some of you may have, but I can't get rid of that. And what you see after treatment is that white stuff is completely gone. All you're seeing is flash artifact. So this is a patient who had a complete response. Okay, now we followed this up. That's a good lead. Now you've got to confirm this. We followed this up with a multi-center trial to see if we could confirm this result. And this involved the University of California, University of Connecticut, and our institution, where the study design was we treated everybody with beta-carotene for 6 months. Now, one of the consistent observations in all previous studies was you stop the agent and the lesion comes back 2 to 3 months, within 2 to 3 months. All the 13-cis-retinoic, all the other studies showed that, and probably because the habits continued. We wanted to see whether, you know, whether with an intense beta-carotene exposure for 6 months, would the lesion stay away or not. So everybody got beta-carotene. People who responded were randomized to either placebo for 12 months, you know, blinded again for a placebo for a 12-month period, or to continue beta-carotene to see if there was a relapse difference. The objectives then were confirm the previous response in a multi-center setting and duration and maintenance of response. This study, this is the first time I'm showing these results. It's just been analyzed. We had 50 patients in this trial. Response rate was 52%, which is right there in the retinoid area. Remember, single institution studies are 70%. That's usually the case. Multi-center is usually 10, 20% lower than that. But this is right in the area where retinoid response rates are. No patient developed cancer, and then some of the details of the responses are there. Pathology, we did have dysplasia, moderate, severe, etc. Just the details of the trial. But again, interestingly, did confirm this is a patient from Irvine with leukoplakia that, again, completely cleared. Now, the next two slides are just to illustrate that at the histologic level also you can see some better differentiation. This is a patient showing some dysplasia. In fact, this was read as moderate dysplasia, has leukoplakia, and this cells are just piled up. This is, fits the criteria of moderate dysplasia. And about a couple of months into treatment, the leukoplakia is still there. This thing on top shouldn't be there. You should have an oral cavity, nucleated cells should go all the way, but the differentiation is much more normal. It's much more sort of smoother, and you don't see mitotic figures and so on. So even at the histologic level, you can demonstrate improvement. Now, the second half of the study, we confirmed the first half. Now, will the responses last? This kind of surprised us. We were preparing to do a 150-patient study initially to see whether, things would be different in the two arms. But 26 patients responded, were eligible to be randomized. 3 patients refused to randomize. I mean, this is what clinical trials are. They said, well, we have a response, and damn if I'm going to go on a placebo at 6 months, and there's no toxicity, they'll continue. So we had 23 patients who agreed. There was no difference in the 2 response arms. The placebo was 2 out of 11. The interesting thing was the relapse rate was very, very low. We were expecting 70%, to be able to show a difference, and this was very, very low. 19 patients went through the whole 12 months without relapse. Now, I don't know the reason for that, but we have a hint from pharmacology, which I'm glad we did in this trial. What we did here was we followed people's blood levels and all, especially after they stopped. If they had a response, we took the placebo arm and continued to measure their levels to see how quickly they'd come back down. Interestingly, it takes 6 to 9 months. I mean, the levels after supplementation increase 20-fold. But the tissue reservoir, this stuff is stored in fat or something, and it takes 6 to 9 months for them to come to baseline. It was totally unexpected. And perhaps offering an explanation, I mean, it messed up our study, we would have liked to, but from a prevention standpoint, this is tremendous that you don't have to take these agents every day. You don't take it for a week or 2. It's not going to do anything to your blood levels once you've reached a tissue level that the reservoir has been filled. So I think this is the only explanation I can think of about why the relapse rate was low, but that's the lowest relapse rate that exists in the literature. So a second study then basically confirmed the trial. Again, there's some data of interest for you. The levels increase. I'll just go through alpha tocopherols, vitamin E. There was no impact on the levels. There's some concern in the literature that if you give one agent, will you lower the other agent? Does it interfere in absorption? We did not see that. The alpha tocopherol levels are pretty much uniform. Beta carotene increases as expected with supplementation. Retinols, vitamin A, there's no change there too. Buccal mucosal levels is the first data on this. Oral cavity levels also increase very nicely with supplementation, and no impact on vitamin E levels in the mouth. So I think the properties are all very good. Now, just a few comments about vitamin E. I mentioned that vitamin E and beta carotene were the 2 interesting agents. Vitamin E has been a little bit behind, but some interesting data is coming out. There's a recent epidemiology study from Maney's group at NIH showing that people who took supplemental vitamin E, this is not dietary, they took supplements of vitamin E had a 50% lower risk of oral cancer than those who didn't. In fact, there are a couple of other trials that have shown that now in the epidemiology area. In leukoplakia, there's only 1 study with vitamin E that was just published, and this was, again, about 12 to 14 center study that had 43 patients. Because it was that big a study, there was a high rate of people who didn't have leukoplakia who got in and had to be dropped out when the biopsies didn't show the lesion. 31 were evaluable. There were 20 responses, and the response rate here, again, if you take the entire 43 is 46%. If you take the 31 who truly got treated, 65%. In any case, a very respectable response rate without any toxicity. Okay, so I think it's pretty reasonable now to say that these antioxidants can produce clinical responses in oral leukoplakia. The impact would be similar if you had an agent that could shrink a colon polyp, for instance, without toxicity. Finally, the issue about second malignancies. Now, I'm going to have you remember the whole slide again about the indirect evidence with laboratory data, epidemiology, etc. We've gone through leukoplakia. Second malignancies is the last point. Agents with efficacy in leukoplakia, the thought is the same defect, the field defect that exists in these patients perhaps from smoking is what leads them to get second cancers. The rate of second cancer is 3 to 5% per year. Perhaps a little bit of toxicity like 13-cis-retinoic acid may be acceptable at low dose because that rate is significant, that maybe a little dry mouth is acceptable. I still have concerns there because these patients have had radiation and all. They're just very difficult for them to tolerate side effects. Now, what has been done? 2 studies have appeared with the retinoids with conflicting results. So I'm not sure whether the retinoids work. The first study created a lot of stirs all over the newspapers and everywhere. In 1990, in the New England Journal of Medicine, this was a trial with 13-cis-retinoic acid at high dose. The main objective was adjuvant. That is, people with advanced disease to prevent recurrence. It wasn't second primary being the main thing. That's why they had patients with stages 1 to 4. Pretty high level. And let me just rush through this. And the problem, again, toxicity was considerable. They had to lower the dose midway through, and most patients could not complete the 12-month plan. And that's the difficulty with retinoids. The important data is here. There was no impact really on the big business about survival and recurrence, which was the primary endpoint. But the second primary impact, it was 24% in the placebo versus 4%. A tremendous difference. And this created a lot of, and this was the analysis done in about 3 years. There was a lot of criticism, but 24% is pretty high, actually, for the incidence. But in any case, it was a very, very significant trial, which people really got interested. Unfortunately, a second study, the criticisms again here, I've really gone through the toxicity as well as the design issues. This was a lead that needs to be confirmed. The first confirmatory data has proven to be negative with the retinoids, and this was a European study using a compound called atretinate, which was just published last year. And again, let me just rush through this. The correct patient group was treated. These were just early stage patients, so you didn't have advanced stage. You're now looking at second primary. Most of them don't die off from recurrence of the disease, and it was a placebo-controlled, very nicely done trial. Unfortunately, at a median follow-up of close to 3 to 4 years, there was no difference in second primary, head and neck second primary or survival. It was really a negative study. So whether retinoids work is still an open question. I think there's more interest in the antioxidant group, and this is reflected here. There's one 13-cis-retinoic acid nationwide study now. There's a lot of interest in this area going on through MD Anderson Hospital, whereas there's a whole bunch of studies across the world that are using beta-carotene either alone or combined with other agents like N-acetylcysteine in Japan, Italy, etc. We'll see what the results of these turn out. These are extremely difficult, really, studies to conduct, as you can imagine. They're not as hard as the 102-year study, but they're still pretty problematic to get the number of patients. You need about 1,000 patients to do these. Okay. Summary slide then. The indirect evidence for antioxidants and a role in the prevention of oral cavity cancer. Now, I started out by saying that the perfect study that I can sit and draw on a piece of paper just can't be done. And let me show you that slide again, the reasons for that. And I'll close by illustrating to you what the problems are when you try to even attempt to do these kind of studies. There were 2 trials published in 1994 on antioxidants and cancer prevention. One was a study from China, where they intervened in Linxia in China, where gastric cancer and esophageal cancer are very, very common diseases. And this is, again, a complex study, and I'll focus on the highlights only. They had 4 arms. Ignore these. The major arm here that showed an effect was the antioxidant arm, which had beta-carotene, alpha-tocopherol, vitamin E, and a low dose of selenium. This study found, and I haven't, I've taken the graphs exactly from the study, a statistically significant and actually clinically important in total cancer death rate. Now, the reason I'm showing you the graphs, this is total cancer death rate. This is out of the population. Healthy people, so this was very, very significant. And when you look at stomach cancer, there was a very significant difference that began to appear within a couple of years of starting the supplementation. And this is all highly statistically significant drop in stomach cancer rates. In addition, there was a 30% reduction in cataracts and a 30% reduction in strokes. Okay, the other areas that antioxidants have been implicated. Now, what was the criticism of this study? Representatives of the population. This is China. They were undernourished to begin with, etc. The only impact was that arm. The other arms didn't have an impact. I presume it was undernourishment, and almost anything should have had an impact. But it's a reasonable criticism. You can't do this in this country because it'll take 102 years or whatever I mentioned before. Okay. Second study is the Finland study that all of you guys must have, New England Journal of Medicine last year, which was a negative study. This was the study done in Finland. The reason they chose Finland is Finland has a social security system that you can track every patient. Okay, what this study involved was they took heavy smokers, 50 to 69 years of age, and this supplemented this way versus placebo. And the findings were there was no effect of alpha tocopherol. This was a 5 to 6 year on lung cancer. There are fewer cases of prostate cancer, by the way, with vitamin E. Nobody understands that. And there's actually a slight increase in lung cancer with beta-carotene. Now, I should emphasize that's the only study that's ever shown that, and there's a lot of concern about the endpoint, the duration of follow-up. However, the criticism again, by the way, the interesting thing is that the epidemiology information in lung cancer was confirmed here. There's people who started with lower levels had more disease. It's just supplementation didn't seem to make an impact. But the criticism of this study, again, I'm showing this from the point of illustrating the difficulty with clinical trials, representativeness of the population. The average age was 57. The average smoking was 20 cigarettes for 35 years. That's about 5% or less of our population. How do you apply that to the general population here? Okay? And in Finland, there's a lot of hyperlipidemia. The diets and all are very, very different from here. The issue about long-term follow-up. I told you about carcinogenesis being the disease, not cancer. Lung cancer, the thought is, from the time that the first lung cancer cell appears to when you see the lesion is a 7 to 8 year growth period. If you look at the doubling time and when you see these lesions grow, is a 6 year follow-up adequate or not? So a lot of criticism. Then the median, how healthy these patients, what their baseline diet are. And finally, there was a lot of concern about the vitamin E dose, which is about half the dose that is thought to be active in all the epidemiology studies. For some reason, they gave 50 milligrams rather than 100 or greater. Okay? Now let me close by, so again, the point of all of that, those two studies, was to show you that we're going to have to make up our mind based on indirect lines of evidence. You're not going to see a study in oral cancer that has oral cancer as the endpoint and starts with healthy people. Okay? Now, why is this area of importance and of interest? If it was oral cancer alone, well, fine, 40,000 cases, etc. But there's a lot of interest in cardiovascular disease. There are at least 2 or 3 studies now, good studies, suggesting a decrease in cardiovascular disease with vitamin E. Cancer I mentioned, and cataract. 6 to 7 epidemiology studies suggesting decreased cataract incidence, and I mentioned the Chinese data with 30% reductions in strokes and cataracts were observed. There is an underlying hypothesis, perhaps accumulating toxin damage or oxidation damage or whatever you want to call it, underlies these seemingly unrelated chronic diseases. So there's a theoretical basis that there is some science behind it that you can come up with a mechanism. Finally, we're not talking about trivial reductions. This is not 1% reduction or 2%. Most of these studies are reporting 25 to 50% reductions in incidence of major diseases. Even if the correct answer is 5 or 10%, with agents that are so non-toxic, I think that would be a tremendous impact on overall disease and overall our overall health experience. Let me stop at that point, and I want to thank you for your attention. Thank you for listening.
We're actually finishing up this morning a little early, which is, I think, a first for our academy. And so what I thought we could do is, if Dr. Garewal and Dr. Ziff and Dr. Briner, we might just do a little panel discussion right now to address any questions that you might have from this morning's session. So would you please, the 3 speakers from this morning, come on up to the panel, and I'll bring the numbers.
Yeah, okay. If you buy it across in any store or the other, it's usually in units. 25,000 units is the same as 15 milligrams of beta-carotene. And most of them will be labeled as 25,000 units, most of the stuff you buy. If you can spend just about 1 minute on why we chose those doses. One is that beta-carotene really has been used up to 200 to 300 milligrams per day in people with diseases like porphyria and all without any toxicity. So this is one thing that we weren't concerned about too high a level. And I'll be very honest with you, the 30 milligrams dose was because that capsule was available initially, to us, that as a single pill per day in a pure form, and we knew the content, so that was 30. We used 30. My own feeling is, and knowing a little bit about the pharmacology, that you probably are not going to get a lot more benefit once you're at about 15 a day. If you if you use 15 milligrams per day, in most people, there's some people who just don't absorb very well, but if you use 15 milligrams per day, it may take you a little longer to reach a blood level that's 5 or 8 times what your baseline level was. It may take you a month, 6 weeks, and 30 milligrams, 60 milligrams, you may do it in 3 to 4 weeks, but that's about the only difference. I think once you're at about 15 milligrams per day, you're probably reasonable, and that's 25,000 IUs.
Thanks. And the other thing I had heard, I don't know if you would agree with this, I'd heard another criticism on the Finnish study that the actual beta-carotene that they gave the people there actually had a dye in it, a yellow dye, which in itself was carcinogenic.
Actually, I would refer people to a series of letters that appeared approximately 2 months or 3 months, the usual response time after an article is published. It was in the New England Journal of Medicine. One of them commented on that issue. And again, I don't know the details. I mean, the preparations are prepared with some dye or the other for color coding. And I think that one of the reasons for doing that is the placebo issue. You know, you can cut these pills, and if the placebo is clear and the other one is yellow, you know, your blinding attempts are totally gone, and patients will do that. I mean, I would do it, I guess, if I was in the art to find out what was going on. Now, so that issue was raised. Again, how important it is, the counterpoint was that was present in the placebo also. So what the implications? I think the main problems with the Finnish study really are representativeness of the population. That is, if you have somebody who has carcinogen exposure, perhaps the disease for so many years, 20, 30 years, 5 to 6 years of intervention, you're really asking too much. So we'll wait. I hope they're going to do the 10-year results and 15-year results. And finally, how do you translate that? That's 5% of our population that smokes like that. If you include the lipid comparisons, you're now down to 2 to 3%. You know, in Finland, there's a lot of hyperlipidemia problems, more cholesterol problems, et cetera, than here. So those, I think, are the major criticisms.
Thank you. Okay, anyone else? Come on up so we can get the questions on the tapes.
Yes, I'd like to address this to Dr. Garewal. I thought that study was real interesting on the beta-carotene when you doubled the dosage from 30 milligrams a day to 60. And if I followed you correctly, that then the relapse dropped to 17% after a year. What was the duration of follow-up on that study?
The study plan was 6 months. Everybody got the active agent, the 60 milligrams, and then we had a 12-month follow-up where everybody who responded would be randomized to placebo or beta-carotene. So once the 6-month period was over, there was a 12-month follow-up on placebo. So total follow-up maximum for a patient would be 18 months, you know, starting from day 1. 6 months would be active treatment for everybody, and then another 12 months where we start. The reason it was designed that way was every previous study that we had seen, done ourselves, and looking at retrospect, the difference is most of those studies, like a 2 to 3 month interventions, maybe the stores don't build up, all of them relapsed within 2 to 3 months.
Wouldn't you be curious as to what the response would be after 2 years?
Oh, I'd love to. You know, at some point, it's difficult to keep people in follow-up. I'd love to see these patients, you know, 3, 4, 5 years. In fact, I want to know what the cancer experience and all would be if we could follow them long enough. Unfortunately, the practicality of these things, the major problem really being, you know, these compounds are so non-toxic, so easily available, and people read about these things. It's very difficult for a person to say, well, I'm not going to take any beta-carotene or whatever for 5 years. Okay. Particularly when they know they have something in their mouth, it's very difficult to do it longer than a year or 2.
Should we as dental practitioners be treating our patients with leukoplakia with beta-carotene? And what are the legalities?
Okay, yeah, that's one of the things I try to emphasize there. Our goal here is not treatment of leukoplakia, and I try to, in medical oncology, I usually try to use colon polyps as the counterpart lesion that we don't. You don't have to treat the small colon polyp or the benign-looking leukoplakia. The goal here is to use leukoplakia as a model to see if oral cancer can be decreased in the population. So if the question was in countries like India, wherever oral cancer is very, very common, where supplementation may play a role in terms of population-wide supplementation, not the individual patient. And unfortunately, I don't want to focus on one patient. Now, if you have a patient, we get calls all the time about people who have the large leukoplakic lesions that have dysplasia and so on, and they don't want to operate because it's too big. Should we try beta-carotene? Fine with me. I mean, that's an individual patient-based decision. I think in this country, recommendations for use of these agents, people will make up their own mind because there's not going to be one definitive study. The FDA requires, randomized control. You're not going to see that. Okay. And number two, it's going to be if we see positive results in 2 or 3 things. Cataracts, heart disease, oral cancer, lung cancer, you can make a case then. Perhaps it's not a bad idea. If you can get the amount, if you can get the amount of beta-carotene that I mentioned, 10 to 15 milligrams, that's the other question we get asked all the time is there a difference between supplement and diet? I think if you can adjust your diet to be able to take 10 to 15 milligrams, it's probably even better.
Dr. Garewal, that's a very interesting study. I don't understand why one would be studying these single items like beta-carotene or alpha-tocopherol when we know that the total antioxidant electron transport chain depends upon all the antioxidants. And we should be really supplementing these patients with also ascorbate, vitamin C, beta-carotene, the alpha-tocopherol, selenium, quercetin. And if you're really concerned about the prevention of cancer, then you should be going to supplementing with all the bioflavonoids, such as genistein, 3-indocarbinol, methylethyl isothiocyanates, muric acid, chlorogenic acid, and also all the bioflavonoids. And if you're going to supplement a patient, then I think it's wrong to supplement with just beta-carotene or just vitamin E. You need the whole antioxidant.
That's a very outstanding point. In fact, all the agents you've listed, you pretty much covered the whole antioxidant program of the NCI. All those agents are being looked at. The question, one is in a study setting. The difference between doing single agent studies to see if beta-carotene is important versus a mixture where you then tease out which one may be, for that particular endpoint that you're looking at. One study was done, it went by too fast, which George Cogers had. He used vitamin C, beta-carotene, and E as a single capsule. The response rate for leukoplakia is about the same, 50 to 60%. The theoretical argument is there. Like if you and let me switch the subject, say, to cardiovascular disease. If you take vitamin E and can do all the lipoprotein oxidation prevention that vitamin E does, etc., will beta-carotene or ascorbate add anything more to that? I think that question is being addressed, is a difficult one to address in clinical trials because each new arm that you add on to a trial means another 1,000 patients or 500 patients for the larger studies. It's a difficult thing to do. My own feeling is, I think even on a theoretical basis, having a fat-soluble compound, a water-soluble compound, to make sure that all the compartments in the body are accessed, makes a lot of sense. There is no answer, really, if you have, say, vitamin E and ascorbate, then do you need flavonoids or do you need selenium? As just unanswered. I think the compounds are so non-toxic that I would have no difficulty if an individual wanted to do that. If they want, I mean, if you have a single pill with all that stuff, that's fine. Otherwise, you're going to have a problem with, with how to actually take those amounts. But it's a question that's being answered. It's being looked at in animal studies, because in human studies it's very difficult to answer. But your point is very well taken.
Professor Steelink.
Dr. Garewal again. I'm wondering if any studies have been done on, I'm a chemist, if you'll pardon the expression, but anyway, on the consumption of tea, a known cancer-causing for the esophagus, and coffee. Both of them have very high concentrations of antioxidants, chlorogenic acid, caffeic acid, flavonoids? Why don't they work also?
I thought you were going to ask a different question in the business about the real interest in green tea and all as a preventive agent. I mean, that there's a tremendous amount of interest right now in looking at green tea versus the processed teas, because some of these compounds are retained in green tea. The linkage with cancer and beverages is there, but it's not the 100% type. You know, every study doesn't show it. It is there. And then the question comes up about whether it's physical injury. You know, I personally happen to believe that if you injure an organ and let it heal in an abnormal environment, you know, you're asking for trouble. So is it heat and physical injury, because where a lot of hot beverages are taken, or is there anything in the content? Green tea as a preventive agent is, in fact, is one of the more exciting things being currently explored in terms, and mainly, by the way, by chemists in terms of ingredients, you know, isolating the compounds and then doing individual studies, which ones are active.